Hello, everybody. So we are getting together to do our town hall meeting for April of 2023. And try to move Ron out of the way here. And we're going to get started with a couple slides from Ron. We're going to go over a number of different things today. We're going to talk a little bit about retention, hospice, QAPI, person-centered care, bloodborne pathogens, Hep B, PPE, mental health, disaster planning, and COVID updates. And as always, as you know, we do these things because we have to be ready for the state. When they come in, there are required trainings that all of us need to know about. So with that being said, we're going to kick it off right away with Ron, and we're going to let him talk a little bit through some customer service.
Okay, thanks everyone. Just a couple of slides here that kind of answer, as Dan said, QAPI and how to identify yourself when answering a phone or entering a resident's room. I'll go with the phone call first, as we have an example here on the slide. If you're at the nurse's station and picking up a call, or really any area in the village at Marymount, an example here is, "Hi, this is SCU, Ann speaking. How can I help you?" Or, "Hi, I'm your nurse, Ann. I'm here to get your vital signs and give you your morning meds." So just identify yourself by name. From a marketing perspective, we have tried to brand our facility, the Village at Marymount, featuring Villa St. Joseph and Marymount Place. So the receptionist at Villa St. Joseph should be answering the call, "Thank you for calling Villa St. Joseph," just like Marymount Place should be saying, "Thank you for calling Marymount Place." Just keep in mind, identifying yourself is really important because sometimes if you're entering a resident's room and maybe they're a little bit unaware, they may become startled if they're hearing impaired, a little combative. So it's just a good practice. And usually when I enter a room, I always show my badge and I state my full name. I say, "I'm Ron Hollowell, Director of Media. I'm here to help you with your paperwork today," state the reason for the visit, and get the resident's acknowledgement before I go into the room. We are looking forward to Nursing Home Week, which is going to be May 14th through the 20th. And as it says here, we do have plenty of fun-filled events and activities to help celebrate this annual week. So check out our bulletin boards for flyers with details. We're moving on here to our QAPI, which is our Quality Assurance Program initiatives. Why they're important? Certainly because they help identify and prioritize problems and opportunities that reflect our processes, functions, and the services we provide to our residents. We really do rely on staff input for some of these projects. If you're hearing things from residents during your rounding and during your interactions with them, that's helpful. And it does allow us to set corrective actions to address gaps in our systems. So again, QAPI stands for our Quality Assurance and Performance Improvement. It is a process to continually look at our programs, services, and systems for ways of improvement. It's based on data, and our staff input is vital to the success of QAPI. And just a quick note on a project I was involved in just before COVID. We do use a survey company called Align, and what they do is they gather data for us in real time with admissions and discharges, but also when a resident is discharged, they received a paper statement in the mail, complete that and send it back to Align. It is anonymous, but from there we get benchmark scores. And again, back before COVID, call light response time was an issue. So an interdisciplinary team of us convened, and we looked at our call lights, the time, the response, looked at data, and through about a 4 to 6 month process, we put some measures in place and got our call lights down to just over 3 minutes, which is a good thing. So again, the importance of QAPI, it does assist us in providing that resident-centered care, teaches how to improve that care for the residents, and it does provide effective change. And again, as I said, ways you can contribute. If you're with a resident, get information about their experiences, and it does help us to teach others as well. and just by participating and giving feedback on projects. And just a slide on person-centered care. Person-centered care really focuses on those qualities of compassion and empathy, respect and responsiveness to needs that all of our residents want. It's basically, we want to adhere and meet their desires. And so again, we put them at the center of our little diagram here, and through empowerment, meaningful relationships, we champion change, agreed upon achievements, we get the outcome that the resident wants on their terms.
Hi, everybody. We're going to talk a little bit about disaster preparedness. So back in 2016, the Centers for Medicare and Medicaid really changed how they wanted senior care facilities to prepare for disasters. I don't know how many of you remember back in the early 2000s and through the 2000s, we had several natural disasters, a couple hurricanes, and some heat waves that caused a lot of deaths in senior care facilities. And that made CMS, Centers for Medicare and Medicaid, realize that we just were not prepared as we should be for those types of disasters and disasters in general. So they really changed the rules significantly. We went from having roughly a 20-page manual to almost a 400-page booklet on disaster preparedness, and we're going to talk about what those changes are. I was not prepared to change. There we go. So how do we start? We start with doing a risk assessment for the facility, meaning what disasters are going to be most likely to affect our building. And not only what disasters are most likely to affect us, but how disastrous would they be for our facility. So you could take something like an elopement. That would be very likely to happen at a senior care facility, especially since we have a memory care unit, and it would also could be very disastrous. It could be life-threatening for that individual, where you might say radioactive fallout would also be very dangerous for our facility and for human life, but it's very unlikely that that might happen to us. So we take these different variables and we plug them into a little algorithm, and we come up with what we call our top 10 things, top 10 disasters, things like missing residents, cyber attacks, heat waves. We have railways and highways close to us, so we'd be subject to chemical spills like we had down here in Ohio in 2023. So those would be how we came up with our initial list of what to look at. So once we've determined what disasters we're going to prepare for, we started to write policies and procedures to deal with all these disasters. You know, one of the common themes is, since we're taking care of people, we've got to have enough food and water, regardless of what happens around us. If it's a tornado or an explosion or a gas spill, we've got to make sure we've got plenty of both. We do keep roughly and probably over 1,500 gallons of fresh drinkable water in storage on campus. We also have emergency contracts with other vendors to try and deliver bottled water if that were needed. We have different menus planned to make sure that we can provide food. Obviously, we've got generators, but we even have plans to get backup generators if those generators don't work. Things like lighting, we've got to have plans for, even a way to get rid of sewage and waste if we can't do that through our normal methods. How do we transport people if we have to evacuate? All these things come together and create our policies and procedures for these different disasters. We even have a communication plan that contains lists of our staff and their contact information for their families and for the residents' families, contact information for doctors and local, state, and federal agencies that that we would need to contact, or we may need their help in an emergency. It's got listings in there for there's several administrative members that have specific job assignments, and those assignments are in there, and we have all been trained on those and have signed off on those. We even have a plan for if the media shows up. If we had a fire, we absolutely would have news crews that would show up and want some kind of statements. And inside these books, we've got pre-scripted statements that could be made to the media. And how do we work with the staff on these? We do it by training and doing drills. So as many of you are aware, we do 12 fire drills a year. I'm sure a lot of you have heard those that have been here for a while. We do 2 annual disaster drills, one in the spring and one in the fall. We actually also do something called a tabletop exercise. That's where the admin team and some staff get together and we just kind of sit around a table and we kind of play the what if game. We say something like, if there's a huge heat wave, how do we handle that? And then, okay, so we're trying to keep the building cool, but what if the air conditioner breaks down? What if the generator doesn't start? And we kind of try to build on that to come up with a really robust plan so that we're prepared for when not only we have a disaster, but when things go wrong during that disaster. Helps us analyze our systems, and it helps us, again, be very prepared for when there actually is a disaster. One of the newer but very important disasters that we're planning for is a cyber attack or cyber security attack. This can happen, either come through email or it can come through attachments in emails. That's probably the most likely way we're going to get those. It could come through portable devices like cell phones. And what they do is they like to hack into a system, they kind of take control of it, and then they lock you out from your data and hold it for ransom and it's usually millions of dollars. And until you pay that, you don't have access to any of your data. And one of the ways we're working with that, we've been sending out these test emails to try and quiz or trap people into clicking on them. That way we can pull them aside and do education to make sure that everyone's well trained and aware of what a fake email looks like, what the latest criminals are trying to get you to do, trying to trick you into clicking on what they need you to click on to get this malware into our system. And also, please remember, don't plug your cell phones into computers. If you have to charge your cell phone, use a standard charging block and a cord, because that's one way that if your phone has a virus on it, it can certainly get into the computer. So a few things I'd really like you guys to take away from this meeting. One is that we've got little disaster boxes at each of the nurses station. Inside those boxes, we've got extra flashlights, glow sticks that you can snap open and put in hallways and put in rooms to keep areas lit. We've got duct tape, knives, some basic tools, things you might need, rope that you could use if you're trying to secure the building or try to help with some kind of urgent need before maintenance or other staff got here. Another very important item is that we don't expect everyone to understand or know what's in all 400 pages of our disaster book. So there is a book at every nurse's station. So if you were in the building and let's say you had a tornado warning and you were not sure what to do, you can go grab this book and you can look up the tornado and you would start following the step-by-step process that we've written on how to address with a tornado disaster. So that's really important that you know that those books are available and that you can get to those books in case of a disaster. You also, most people have been in service in one way or another if they have a specific role in this to play and if there's a disaster. And I wouldn't be surprised if in the next couple of years we see even more drills required for different types of disasters. And that's it on disaster preparedness. Thank you for checking out the meeting.
Thank you, Bill. Appreciate it. We're going to jump on to real quick. We're going to talk about mental health, and we're going to talk about it with our nursing home residents. As we all know, mental health is prevalent in nursing home residents because of the fact that sometimes just what they've been through in their lives and also what they've been subject to oftentimes with really being excluded or being isolated in the community. And these are things that we have to keep in mind as we're taking care of these individuals. A lot of them have been through things like war and in battle, and or maybe been through some sexual abuse or had a history of sexual abuse. Either way you look at it, we have to know their history and we have to understand the behaviors that sometimes go along with that. So, what causes mental health? Well, there's a couple different factors. You have emotional abuse that they may have undergone. You have old age, which unfortunately just brings about some areas of mental health. Poor lifestyle. People that spent their lives doing things maybe they shouldn't have, and now it's starting to get back at them. And then isolation. This is something we saw a lot with the pandemic, is that individuals are isolated. When they're isolated, they oftentimes go into depression, anxiety, and those things sometimes can be helped by counseling and medications. And that's why we need to know what to do when we see these things and what are we looking for. We want to be able to see, is there a change in somebody? If somebody all of a sudden is more tearful or they're not eating or they're isolating themselves, these could all be parts of behavioral health. It's important to report those changes in behaviors to our social service team, to the physician, to the medical staff, to see if we could do something to help. It doesn't always have to be medicine, but maybe it's just a counselor or a psychiatrist or psychologist that sees them. And we have them in-house and we can make sure that those individuals are seen. So please, if you see changes like that or you see behaviors around mental health, let someone know. Also want to talk a little bit about some HR incentives, one of which is our retention bonus for our nursing staff. We really want to encourage our staff to bring on friends and family, good staff members in the community so we could fill our building with good staff. And in doing so, you'll get a $250 retention bonus at 30 days and then again at 90 days. And that's going to be not only for you, but the individual you bring on board. If you bring in a nurse, it's 500 and 500, which I think is great. Please, we want to give you this money because we want those staff. We are putting a full court press to move away from agency, and that's really what we want to do. So next thing I want to talk about is COVID updates, and these are important because there's a lot of talk about masks going away, and we are in fact going to be looking to remove masks as well. But there's a couple conditions. First and foremost, if the county is at a high level, meaning it's red in its community transmission, then we can't go out of masks. We are fortunate enough right now that the county is in orange. So be it that they're in orange, we can go outside of masks. The other way we can go outside masks is if we haven't had any cases directly affecting patient population or deemed by the county as affecting us for 14 days. Now, if we have a brand new patient that has a case, then that means we're back in mask for 14 days. And lastly, if there's been an exposure, you're going to have to wear a mask, or we'd ask a family member or anyone along those lines to wear a mask. So really it comes down to, if the county stays out of red and we don't have any new cases, then we could come out of mass. But on a moment's notice, we have to be able to switch back into mass. So when you get a phone call, if you get the text messages and it says we're back in mass, then we're back in masks. So without hesitation, we are going to put up a little sign at the front desks to help everybody and remind everybody. We're going to be putting out calls. We are hopefully going to put this in effect May the 2nd. So starting on Tuesday, May 2nd, we are going to go with no masks. But again, if anything changes, be ready and prepared to go back. And last but not least, if you are not vaccinated, that means you have an exception. You never received the initial 2 vaccines and you have not received the 1 bivalent. So the 1 bivalent now will consider you vaccinated, even if you've gotten no other shots before that. But if you have not gotten any vaccines whatsoever, you still must wear a mask. So Remember that we do have a list of those individuals that are working here, so please keep the safety of our residents at your highest regards and wear your masks. We had the Ohio Department of Aging came in back in February. They did surveys of our patients directly with the patients, one-on-one, no other outside staff, and we fared very well. We were very happy with our scores. Marymount got a 92, Villa St. Joseph got an 81.7, and MCU got an 87.6. Put into context, I believe last time they did these, assisted livings averaged around 85. Skilled nursing facilities averaged around 75. So you can see that we are well above the last averages. We'll have to see where they come out when the official rules or the official findings come out in the fall. But you can see we scored very high in many areas over Marymount Place. Environmental care and services both scored 96 and above. Over at the Villa, we had good scores in dining and meals and environment and caregivers. And down in our MCU, caregiver scored very high. So all very nice to see. So also was asked to talk a little bit about transition to Wellstone. So wanted to bring up that at this point, the TPA, which is kind of like signing the final paperwork of buying a new house, kind of got started. Finally went in about 2 or 3 weeks ago. That process normally takes about 60 to 90 days to convert, but I think that is a great start. And it just seems like a couple months we'll be making our full transition, but we've been working alongside with them every step of the way. We've continued to meet weekly on operations. Like any corporation, they're not here all the time. They're out of state. They have another 6 buildings that they're in and out of, but they'll be coming through this week. And we do see faces like Michael that are oftentimes here for the dietary. But if you have any questions, please feel free to ask. At this point, Mark, are you on the call?
I am.
So I'm going to hand it over to you, Mark, and I will move your slides for you.
Okay, we're going to talk a little bit about hospice, which is a comprehensive set of services that provide physical, psychosocial, spiritual, and emotional needs of terminally ill residents and or their family. The facility works with many contracted hospice providers in the delivery of a shared plan of care. Do know that we welcome many different hospices into the building, and they are regulated through the same state of Ohio Center for Medicare and Medicaid Services as us. And we need to make sure that the hospice services we work with are in line with the Sisters' mission. So a very important part of working with hospice is the communication piece between Villa St. Joseph and the hospice provider. Any changes to orders initiated by hospice need to be communicated to the resident's attending physician here in the building in a timely manner. And we must also communicate with the hospice regarding orders provided by the resident's attending physician here at VSJ. We need to immediately contact and communicate with hospice regarding any significant change in resident status. Such changes might be unexpected decline in condition or a fall or consequences related to medication or therapy. So we want to be good partners with our hospice providers. We're going to talk a little bit about infection control and bloodborne pathogens. Even though we are in a healthcare environment, germs are present here, and they can be found on dry surfaces, wet surfaces, and indwelling medical devices. Dry surfaces would be countertops and tables, bed rails, medical equipment. Wet surfaces would be sinks and faucets, tubs and showers, and things of that nature. And indwelling medical devices would be like an IV line or an indwelling Foley catheter. So who is susceptible? We are all susceptible to some degree, but people who are not vaccinated or immunocompromised would be more susceptible. Someone who has a way for germs to enter. For example, if they have tubes or a surgical incision or an IV catheter. People with underlying medical conditions are at increased risk to be able to fight infections. For example, people with diabetes, cancer, or organ transplant recipients. Some treatments increase the risk. Those that are on antibiotics, steroids, and certain cancer-fighting medications can weaken the immune system. So transmission is the way germs move from one person to the next. That can be by touch. Want to keep our hands clean, touching a contaminated surface, and then touching another person, shaking hands, or even rubbing our own eyes. Sprays and splashes. If the infected person coughs or sneezes, creating droplets, those droplets can carry short distances, up to 6 feet, and can land on a susceptible person's eyes, nose, or mouth, and can cause infection. Also by inhalation, germs are aerosolized, and from people coughing or even talking, and certainly sneezing, tiny particles survive on the air and can travel great distances, especially if there is like HVAC, heating and cooling running. So those currents are going through the air, carrying droplets. And then lastly, Sharps injuries. So if a nurse has a needle stick, that could be another port of entry. So what would be considered an exposure? An exposure incident is a specific eye, mouth, or mucous membrane or non-intact skin contact with blood or other potentially infectious materials. Exposure incidents should be reported immediately to your manager and to HR. Go ahead there, Dan. Okay. So what should you do if you have a needle stick? You're going to wash the needle stick with soap and water immediately. Um, Flush splashes to the nose, mouth, or skin with water if there is contact in any of those areas. If there is contact to your eyes, you want to irrigate eyes with clean water, saline, or sterile irrigates. And you want to report the incident immediately to your supervisor and HR for further direction. So PPE, a little bit about PPE, we're all familiar with that. Gloves, you want to make sure that they fit correctly. You don't want to wear gloves that are too large or too small. The gown should fully cover your torso and fit comfortably over the body, have long sleeves, and fit snugly at the wrist. The mask is there to protect your nose and mouth, must cover both of those. And goggles should fit snugly around the eye. Personal eyeglasses are not a substitute for glasses. So some do's and don'ts of glove use. You always want to work from clean to dirty. Limit opportunity for touch contamination. Don't touch your face or adjust your PPE with contaminated gloves. Don't touch environmental surfaces except as necessary during patient care. And change your gloves often. Change your gloves during use if they're torn or they're heavily soiled, certainly after each patient. Discard your gloves in the appropriate receptacle and never wash or reuse disposable gloves. So PPE sequence for putting on your PPE is gown first, then mask, then goggles, and then gloves. And then we're going to go over the sequence for removing your PPE. And you want to remove gloves first, then goggles, gown, and your mask last. And always wash your hands immediately after removing PPE. Little bit about hepatitis B. It is a liver infection caused by the hepatitis B virus. It's transmitted when blood or another body fluid from an infected person with hepatitis B enters the body of someone who is not infected. Best way to prevent it is to get vaccinated. We offer the vaccination for all employees. Even if you've chosen not to be vaccinated, you can change your mind at any time and you just want to see HR and we can help you get vaccinated. So this ends the town hall portion. The next portion we're going to go on to is for nursing only. So we'll pause just for a minute here and then move on to the nursing portion. So for nurses and STNAs, we want to talk a little bit about the best way, the correct way to communicate orders. When entering orders in PCC, it's important that nurses select the correct individual from whom an order is taken. If an order comes from a nurse practitioner, then that name should be on the order. If it comes from the physician, that name should be used. Each individual now is signing for their own orders that they give. So in the past, we have put almost all of Dr. Lewis's under his name, but if his nurse practitioner, Lydia, writes the order, we have to use Lydia's name and she will sign off her orders. Dr. Lewis will sign off his own. And that would be the case with any other physician or nurse practitioner. When communicating methods of orders, we do want to choose the correct way that the order was communicated. A phone order means the physician called on the phone and communicated the order to the user. Those triplicate, we call them phone orders that are in the charts, the hard copies that we write on, those are called phone orders, although we can use them as prescriber written and verbal. So a verbal order means the physician was present and verbally communicated an order to the user. A lot of times we track down the nurse practitioner or the physician in the building. We go up to him or her and update them on a resident's condition, and they may give you an order that is considered a verbal order if they communicate it that way. A prescriber written order means the physician wrote the order on a prescription pad and signed it, or on a telephone order. As long as they signed it, then it's considered prescriber written, and we don't have to track them down for an additional signature. We're going to talk a little bit about falls and how the details matter. We take falls very seriously and talk about them every morning in morning meeting, and we go through what we could have done to prevented it, have prevented the fall, and how to prevent future falls. So one of the things that's helpful is to make sure that you include descriptive details regarding the positioning of a person found on the floor. Too often, we will get a fall report that just says found on floor. But if you can be really descriptive, it helps us to understand what the resident might have been doing and how they ended up on the floor. You must inform the physician and emergency contact of every fall. This needs to be documented in a progress note. If you call a family member, if you have a fall at 2 o'clock in the morning, you do need to call them at that time and tell them about the fall. If you leave a voicemail, you have not notified the family. You have left a message that they may or may not get. So if that's the case, you have to pass on to the next shift that they need to attempt to reach the family. And then if you speak to someone, you have you've actually contacted them, and your note can then reflect that. Don't forget about the batch orders to enter the 72-hour charting, as well as neuro checks. They are an easy shortcut to make putting those orders in. They're very easy to do. Just use the search field, put in the number 72, and you will find the batch order for the fall notes for the 3 days. Just a couple things about admissions and discharges. It's becoming more common for second shift to have to help with admissions, but specifically assessments. If you are assisting with an admission, please make sure the assessments are complete and that you obtain a wait. If you are working night shift nurses are responsible for the discharge assessments. That is not something for the supervisors to be doing, although they can help you. If you are working night shift, you are the nurse for someone discharging the next day, you must do the assessments. You should be aware of your residents who are discharging the next day and help make that process a smooth one. Call light response. We are all responsible for answering call lights. I think everybody knows that works here at VSJ. It is not solely the responsibility of the STNAs, although they are often the first ones there. Nurses, any staff walking by can answer a call light, and there have been some pretty long call lights, especially on night shift, that we really need to correct. We need to make sure that we are getting on top of those call lights, and if there are long call light responses, we need to find out why. What is the root cause of that? Don't cancel a call light until the need has been met. If you go in and the need requires 2 people, leave that light going until you go and get your partner to come in and help with whatever that request is. A little housekeeping commentary about cleaning up after ourselves. We need to make sure that we are keeping the units looking neat and clean, the residents' rooms. Things like pumps and commodes and other equipment that are no longer in use need to be cleaned and taken to the clean utility room. Glucometers need to be wiped down after every use. Please don't walk past garbage on the floor. It's especially embarrassing if you're walking with a family member and you see a glove in the middle of the floor. Any one of us can stop and pick things like that up. Nurses, please make sure that you are cleaning the nursing cart and stocking it for the next shift. We've got a new breakfast delivery schedule on CCU. The kitchen is now trying to get breakfast up to CCU at 8 a.m. So we've got to work a little harder to get people up and ready for breakfast at that time. I think it's going pretty well right now. It's a little rocky in the beginning, but everybody has pulled together and that seems to be working out fine. Latoya Thomas is our new admissions nurse. She's worked on SCU as nurse on the floor and charge nurse, and she is now working in admissions. So congratulations to her. And lastly, we'll be celebrating Nurses Week, May 6th to the 12th. We have lots of fun things in store for that. STNA Week is a few weeks after that. And we're actually going to end it here. There is an in-service for the nurses, but that's being taken care of on a one-on-one basis. So that ends it here. Dan, I don't know if you have anything else to say.
No, just want to say thank you to everyone. Again, a reminder that you need to complete the in-services and complete the quiz that you could get from Brenda in HR to say that you did your town hall meeting. And be on the lookout for those changes with the mask wearing. We're very excited to make this next step in walking away from the pandemic, we hope, very soon. And just thank you guys for everything that you do for our patients every single day. We appreciate you all so very much. Have a wonderful day. And enjoy the in-service. Thank you.